Good day, everyone. I'm delighted to join you today for this very important discussion on the critical public health issues faced in the Asia Pacific region and their implication for women. I have been a long-time senator and advocate on public health issues. I chaired the Committee on Health for many years. I've always realized that there has to be a way that we can intertwine the relationship between sustainable development, health, education, women, and all these other important facets of our lives. I'm finding more and more connectivity between all this through the work that I do in the Sustainable Development Committee that I chair. It's actually the Committee on Sustainable Development Goals, Innovation, and Futures Thinking. So we recognize that gender equality, which is SDG 5, is essential to sustainable development, along with realizing the people's right to health, which is SDG 3. And so in all my work, I've woven the importance of health into almost everything that I work on. Over the years, as I've done the Magna Carta of Women, which was a law we passed in 2009, the Expanded Breastfeeding Promotion Act, which we passed in 2010, Responsible Parenthood and Reproductive Health Act, which was in 2012, the 105-day expanded maternity leave, which was in 2019. Obviously, all of these laws have a special focus on women precisely because as a woman, I recognize that there really is a need for laws on healthcare that are directed to the needs of women. And with these laws, we raise awareness of the vulnerable position that women have always been, and to a certain extent probably will always be, because we have unique characteristics for childbearing. When we become mothers, the possibility and the advantages of breastfeeding are there, and thus the maternity leave. So all of these are intertwined. And thus, in my work, I have always had that special focus on women and our needs. So what I have done to ensure gender-responsive implementation is, one, ensure that existing laws are fully implemented and properly funded. That's not always possible because, like in the Philippines and many in the Asia-Pacific region, we are vulnerable to climate change. We live in a typhoon zone. And so even though women and children are mostly affected during these calamities, it's also the budget that would normally sustain them that gets affected. Number two, sufficient and far-reaching information dissemination about public health programs and services. An example would be, it is always known wherever we are that mothers sacrifice their own selves for the benefit of their family, and so they'll put on the sideline or behind their own health. And so we have to keep on informing them of the need for their checkups, their pap smears, their breast examinations. Number three, providing gender and development training for healthcare providers. Number four, developing strategies and policies that reflect women's dual role in society as co-equal providers and as primary caregivers, including recognizing that women are providers and recipients of healthcare, especially in the homes. This is a long discussion because I think in many societies, women do carry the primary burden of household management, including being caregivers. And so it is important that we discuss this and have strategies and policies that will support these women's dual roles, and of course spread out the importance of their jobs in spreading out the management of the household responsibilities. Gender and sustainable financing. This is a very important topic because without specific interventions, budgets may not necessarily be gender sensitive. So in the Magna Carta of Women law that I mentioned, it is very specific there that 5% of the total budgetary allocation must be utilized for gender and development. There's a lot of room for improvement, but at least that gives people a bird's eye view, or it gives them the mandate exists to ensure that this happens. Meanwhile, under the Universal Health Care Act, the National Health Insurance Program under PhilHealth was established to provide health insurance coverage and ensure affordability, acceptable available and accessible healthcare for all. So again, when I say for all, this does not even account for research that may ensure that ailments that are particular to women have been identified and are being treated. So we need to go deeper because, again, there are specific health needs for women. So there's much to be done. We recognize that health is a fundamental right that is indispensable to the exercise of all other human rights. And as a legislator, it is our duty to affirm the rights of our people to the highest standards of health. It's work in progress, but we always have to set the benchmarks. We always have to keep on learning and sharing with each other's fellow members of parliament on what we can do to ensure that women are not left behind. And a multifaceted approach involving policy reforms, capacity building, social empowerment is needed to address gender-specific barriers and to promote equitable access to healthcare for all. Thank you.
All right. First of all, thank you so much for joining today. We are very thrilled to organize this session on Parliamentarians Unite for Global Health Equality. Before we start with the questions, I'd like to do a quick round of introductions, starting with myself. I am Paramita Roy. I am the regional coordinator at Asia Pacific for Unite. And I'm also the moderator for today. Along with me from Unite, I have Joanna Perez, who is the Policy and Programs Officer at Unite. We also have Abdul, who is the regional coordinator for the Africa region. And we also have Beatrix, who has joined us today, and she is the policy coordinator for the she's the policy coordinator for the drug policy desk. And we also have an esteemed line of speakers joining our panel today. So we have Honorable Agnes Lam. Honorable Lam is a poet, educator, journalist, and politician in Macau. Welcome, Honorable Lam. We have Honorable Fauzia Khan. Honorable Khan is a member of parliament from India. She is a member of the Rajya Sabha, which is the upper house of the Indian parliament. Welcome, Honorable Fauzia. We have Honorable Fiona Patten. Honorable Patten is an Australian politician. She was a member of the Victorian Legislative Council between 2014 and 2022. Welcome, Honorable Patten. We have
Thank you.
Honorable Senator Dr. Sania Nishtar. Sania Nishtar is a member of the Senate, which is the upper house of Pakistan. Welcome, Honorable Nishtar. We have Honorable Habibe Millat. Habibe Millat is a Bangladesh Awami League politician and the incumbent member of parliament from Sirajganj too. Welcome, Honorable. We also have Honorable Sophia Moermond. Honorable Sophia Moermond has been a member of the Legislative Council in Western Australia since 2021. Welcome, Honorable. And we also have Ravindra Garimella. Ravindra Garimella is a former parliamentary officer in the Lok Sabha Secretariat, which is the lower house of the Indian Parliament. Thank you so much for everyone for joining today.
Thank you. It was my pleasure as well.
Great. And
Okay.
before we start with the questions, I had a small presentation prepared for Let's Talk Health to introduce the idea amongst you all and also talk about why this session in particular. So if you may allow, I'll share my screen.
Yeah, sure.
Can everybody see my screen?
Yes.
Yeah.
Yes.
Perfect. So this is the episode Empowered Voices, Parliamentarians Unite for Global Health Equality. But firstly, let me tell you about what is Let's Talk Health. Let's Talk Health is an empowering conversation series which is dedicated to addressing critical public health topics in the Asia Pacific region. What is our mission? Our mission is to engage parliamentarians in meaningful discussions, fostering collaboration, and raising awareness in the process. We envision a transformative space where parliamentarians come together to share experiences, prioritize policies, and explore innovative approaches. But most importantly, the APAC region, which is the Asia Pacific region, is home to diverse populations facing various health challenges that demand tailored and location-specific interventions. And by organizing such a conversation series around public health in APAC, we at Unite can directly interact with parliamentarians and gain a deeper understanding of their specific challenges and in the order devise effective strategies to those challenges. And why this session about women in health? I think the agenda was to understand how health policies affect the lives and realities of women in the Asia Pacific, to re-envision our perspective on health matters by embracing a feminist viewpoint, an aspect which is frequently overlooked in traditional literature, And finally, to harness the power of you all parliamentarians to advance gender responsive policies and champion global health equality. So if I will start with the questions right now, and firstly, we'll take question from Honorable Agnes Lam, and we're going to touch upon a very important topic, which is universal health coverage. Honorable Lam, as we know that universal health coverage is a crucial goal for ensuring equitable access to healthcare services. In the context of Macau, how does the gender intersect with the implementation of UHC? Are there any specific challenges or barriers that need to be addressed to ensure that UHC policies and programs adequately address the unique healthcare needs and concerns of different genders? And what initiatives or policies have been advocated for to promote gender-responsive UHC in Macau? Honorable Lam, the floor
Sure.
is all yours.
Okay, thank you very much, Honorable, for your question. And so I think in the context of Macau, most of our healthcare policy, when we need to access to policy, we do not have a gender-based, gender bias in Macau. And so male and female, actually here we enjoy the same policy according to age, family income, and if the person is physically or mentally disabled. So we're not here advocating the gender equity, but rather what we need is a more specific approach to healthcare needs and healthcare concerns according to different gender. So here we call it as to promote gender responsive healthcare, which accounts for different health needs and experience of men and women. So for example, what we found is that I did a survey in 2008 and to understand women's need in both physical and mental health. And later we find very soon that women that in the kind of from the more marginalized group, lower income family, they may not care themselves enough. Okay, they concern a lot of their family members, husband, children. And so then what we need to do at that time is that even the government provide free access to gynecological examination. But most of the women that they're just from the lower income families, and then they don't even go to check, they don't even access to this kind of free scheme. And so one thing I advocate at the time was that, okay, we need to go to the communities and to really connect themselves to all this healthcare. So I think our concern here is that Macau is kind of rich in terms of GDP, but then we still have a lot of disparity in policy when we're talking about how we implement it, and especially that women from the lower income family, they are usually lower informed of all kinds of available policies. So one thing we need to do is really kind of promotion and engagement. So I also kind of advocate a lot in the assembly. In my last term, there is that the family-friendly policy, we need to do it because once we try to promote family-friendly policy, we can encourage the employers to promote health concern among the employees and also kind of encourage female employers to kind of frequently have their body checked. And so I think that's also kind of important. So I think that here in Macau, what we really need is the gender responsive advocacy, health advocacy. I hope I respond to your message. Yeah.
No, Honorable, thank you so much. I think those are some excellent points. I absolutely agree with the part where you said there's information asymmetry and engagement and advocacy is what we need at this point of time. Thank you so much. I'll move on to the next speaker. The next speaker is Honorable Fauzia Khan. Honorable Khan, if you could please let us know about the major public health challenges which are specific to women in India and how can gender responsive policies be integrated into the national healthcare systems to address these challenges effectively.
Yeah, thank you very much, Paromita. If I'm right, India, like other countries, faces several public health challenges that disproportionately affect women. And one of them is maternal mortality. Here, people living in remote areas where healthcare access is very remote for them, their complications during pregnancy and childbirth, hemorrhage, infections, such things lead to maternal mortality. And right now, the maternal mortality rate in India is 97 per lakh live births. There are also reproductive health issues. There are problems with family planning, low contraceptive use. There are, high fertility rates, unwanted pregnancies, several things related to reproductive health. Then there is one major problem, which is anemia and malnutrition. In certain pockets, these are very, very important problems. And it is prevalent all across rural areas where the anemia rate is not only rural, but even urban, even in good families. So it's more about awareness of what to eat, what is a balanced diet. I think that matters. And because of malnutrition and anemia, you have malnourished children who are born to girls, especially who are married at an early age. Then you have problems of non-communicable diseases like diabetes, like cardiovascular diseases and cancers, which are on the rise. These are some especially related to women health challenges. You have mental issues like depression, like anxiety, which are left uncatered due to the social setup. We also have problems like violence against women. You have domestic violence, you have got sexual abuse, you have trafficking. All these problems are there in women, particularly lack of healthcare access. Because of India is a very large country and you have all kinds of terrain here, hilly regions, you have very remote regions, you have got places across rivers and things. So approachability of healthcare is also a major challenge here. There are sexually transmitted diseases where lack of awareness plays a very important part. And that is why gender responsive policies must be integrated into the healthcare systems in India, and it is there. In fact, you have got a separate section of healthcare where you have reproductive health and childcare and all that. But there are certain strategies which must be improved here. And one is that maternal healthcare systems have to be improved, especially access to healthcare has to be made, still strengthen it. We have a very good system. We have sub-centers which cater to almost 1,000 population. And we have got these ASHA workers. ASHA workers are in every village, there is a lady who looks after the health of the entire village. So these ASHAs are trained and they are made, strengthened to give immunization, to give other things. That is why this ASHA network in India is a very powerful network, and they have been working as frontline workers throughout the COVID period also. You have got, you need to work with increasing awareness, as my colleague was rightly saying. We need to work more on nutrition and anemia, because here also it majorly deals with awareness than other things, but folic acid tablets and all are also distributed. Also for non-communicable diseases, especially cancer, this incidence is very, very swiftly rising. And I think we need to have more hospitals, more tertiary care centers, which are accessible to the poor population all across. We have to combat sexual violence. We have got laws in place, but still these menaces continue and we have to keep working with it. So I'll take it further as it comes. Thank you.
Thank you so much, Honorable. I think you have raised some valid concerns that deserve attention. Thank you so much. We'll move on to the next speaker. The next speaker is Honorable Fiona Patten. And Honorable Patten, during your tenure as a Member of Parliament in Australia, you have been a strong advocate for drug policy reform. And it is well known that drug use and its consequences can have a differential impact on individuals based on their gender. Could you elaborate on how gender plays a role in the drug policy reform, particularly in terms of addressing the unique needs, challenges, and experiences of women in relation to drug use, addiction, and access to healthcare services. The floor is all yours.
Thank you, and thank you for organising such a wonderful panel, and posing such questions, because sometimes they are wicked questions, and it is difficult. And we know for women, particularly around drug use, stigma affects them even more profoundly than our male counterparts, and which leads them to not being able to access services because of the stigma, but also because many women are still the primary caregivers of their families, and they're looking after family. So to access treatment without childcare, without the ability to bring their families, without the ability for someone else to look after their families, even the research that we do into the impact of different illicit drugs are different for women as compared to men, but there's very little research into how drugs impact women. And in particular, when we're looking at recovery, and if we're looking at, opioid replacement therapy, for example, our research into those treatments has largely only been done on men. It has not been done on women. Women are excluded. So I think of an example in my territory where I fought for a drug overdose prevention centre, and this enabled people who used injecting drugs to be able to use them safely and have a doorway into other services, into treatment services, into housing services. But if a woman was pregnant, she was excluded from that service. And yet this would be a person who'd be at their most vulnerable. If they are injecting drugs and they're pregnant, we should be opening our arms to them, yet our policies don't allow for that. And so we find that we sometimes stigmatize and reject some of the most vulnerable women who use drugs. But it also comes down to women being hidden. So women won't come forward about their drug use. They're quite often, we've seen not anecdotally, but our research shows that quite often they're looking after a partner who is also using drugs, and they take on that caring role for their partner, but also for their family. So when we design services for women who use drugs, we need to take into account that they have children. We need to take into account that they may well be looking after a partner. We need to take into account that they may also be experiencing family violence in that circumstance. In Australia, and Australia again, like Macau, is we are a wealthy country, but we have very vulnerable communities. And we think of our First Nations women, our Aboriginal women, they are so ostracized and so stigmatized, and geography makes it impossible if they're living in remote areas. And I'm sure Sophia from West Australia, which is much larger and much more remote, like India, just accessing those services is so difficult, and especially for women, because they are so often looking after their family as well. We've seen it's even just, and I'll end shortly, but I was just speaking to a woman today whose daughter became addicted to methamphetamine, and she spent years trying to find treatment for her daughter. And fortunately, it's a happy story, and her daughter was able to find treatment, and her daughter is on a path of recovery and is well. But her daughter was on the autism spectrum and had ADHD. Now, we rarely diagnose girls with autism and ADHD. We much more often see it in boys, and we're starting to see emerging evidence that people, as we know, people use drugs to self-medicate, and we're finding, particularly with drugs like methamphetamine, that there is quite a considerable amount of self-medication for disabilities like ADHD, yet women and girls are very rarely diagnosed with that. So, I mean, it's a conversation for a whole conference, I think, but I'm so pleased to be part of this conversation. Thank you.
Thank you so much, Honorable Patten. You have provided a compelling perspective with personal anecdotes, and I truly believe that you have such a strong grasp of the subject matter. So thank you so much. We'll move on to the next speaker, Senator Dr. Sania Nishtar. Dr. Nishtar, as during your tenure as Minister of Social Protection, what measures did you take that were gender sensitive with respect to the health sector, and what challenges did you encounter?
Well, thank you for that question, and congratulations for commencing on this series of very important conversations. So I served in the cabinet of Prime Minister Imran Khan over 3.5 years, starting from early 2019 to April of 2022. And during that time, I was responsible for executing a very large program called Ehsaas, which means compassion in our local language, Urdu. Ehsaas was a social protection program. It had a budget of over $1.5 billion a year. It reached out to 15 million households. And it had a basket of welfare services for different target audiences. So it had cash transfer initiatives, both conditional and unconditional. It had care services for different categories of disadvantaged individuals. There were poverty graduation programs. And then there were digital programs to enable targeting of subsidies. In all, there were 16 programs. And within the basket of those initiatives, we had an overarching umbrella policy, which was called the 50% plus Ehsaas, which meant that more than 50% of all the benefits, all the programs, all the initiatives of Ehsaas were meant to favor women. But by the time our government left, this program turned out to be a 98% Ehsaas, which meant that 98% of the budget went in the hands of women. And in that 50% plus framework, we took a number of different steps. For instance, number one, the unconditional cash transfer went exclusively in the hands of women. Secondly, for the conditional cash transfer programs, and we had a health and education predicated conditional cash transfer and another nutrition predicated conditional cash transfer, we took the fundamental decision that the girl child was going to have a higher stipend. So Pakistan became one of the few countries in the world where the girl child was given a higher stipend amount if the family complied with certain health-centered, nutrition-centered, and education-relevant conditionalities in the conditional cash transfer programs. And that was the second policy intervention that we did under the 50% plus framework. The third decision that we took was that when it came to scholarships, especially the undergraduate scholarships, and the loan program, and the asset transfer program, which were also part of the social protection bracket with deep interlinkages with health, we would make sure that 50% of the benefits would go to girls and women. And it was very difficult to get the system to comply with this, because over and over again during steering committee and review meetings, I would hear from vice chancellors, I would hear from bank executives, I would hear from NGOs who were executing the program that it's very difficult for, to motivate women to come forward to access loans. It's very difficult for women to access undergraduate scholarships. And over again, we would re-emphasize that, no, you have to go back and make a proactive effort. So I think that in terms of enforcement, data are very important. Data, review, cadences of review, and a mechanism to ensure accountability. Because just stating as a policy measure that this is what we're going to do, and then just to leave it at that is not enough. You have to ensure. And I know that this is a session focused on health, And here I'm talking about social protection, but I'm sure all of us are aware that per capita income is one of the strongest determinants of health status achievement. The second important determinant of health status achievement is female education. So there are deep interlinkages with the world of social protection and with the world of health. And we felt that with this measure, we were really on a journey to impacting over a period of time, impacting the health outcomes of women and girls in our country. Over back to you.
Thank you so much, Honorable. Those were some insightful observations. The next speaker is Honorable Habibe Millat. Honorable Millat, I think we're going to touch upon the topic of maternal and reproductive health, which is, as we know, a critical aspect of women's well-being, and Bangladesh has made remarkable strides in reducing maternal mortality rates. However, there are still challenges related to reproductive rights, access to family planning services, and addressing gender-based violence in the context of reproductive health. What steps have been taken in Bangladesh to address these challenges and improve the overall reproductive health outcomes for women in Bangladesh? All over to
Thank you. Thank you. As you know, Bangladesh is one of the densely populated country in the world. It's about 180 million people lives in a small country. Over the last 15 years, there is a huge improvement on the economic, there is huge growth in the economy. As we said, the per capita income or GDP growth has, GDP growth has increased about 6 times over the last 15 years. Health budget is also gone up, but we want more in the health sector. And unutilized, inappropriate also there. But in the especially women's health care, when Honorable Prime Minister took over 15 years ago, Sheikh Hasina, she has given special emphasis on women empowerment and women independence. So she worked hard on that. As you see now that women in 2012, our child early marriage was around 67%, one of the highest in the world. Now, last 2 years ago, it shows is 51% a child marriage. So it's 18% or 19% reduction is for the 180 million people is a huge, because our population 50% male and 50% female. And we have another thing is that in the education sector, I'm talking all those things because of if we go to the maternal health or we go for other issues, all are important. That women has empowerment, that they have started earning or they are having good education. As you see, yesterday we had a SSC or school level exam result was published. And we saw that girls are doing much, much better than the boys. About those who has done very good result, 65% are girl, boys are about 35%. And if we go to the university, medical college or engineering college, in our time as a doctor, I saw it, girls' participation was less than 20%. Now it is 65 to 70%. Girls are studying in the higher studying than the boys. And if you go to the job sector, especially administration and government job, the women are doing much better than the men. As you see, the maternal health, child health, reproductive, all related. We saw that child marriage can increase death of the women around 4 times the normal death. We have achieved MDG in neonatal or child mortality, but we have not achieved maternal mortality yet, but we are close to the target. And SDG, we are working on that. As you see, the maternal, we didn't have that care in previous year. Our almost 80% or 70% was home delivery during the time with the untrained traditional birth attendant, but the things have changed. The government, Sheikh Hasina's government, have taken initiative, and about already 3,000 midwives. Number is not enough, but still we have trained them, we have educated them, and we have employed them. And also another 15,000-20,000 on the pipeline. And also we increase the doctors' number, about 15,000 doctors, 25,000 nurses add to the health system. And also we have 70,000 health assistant and family welfare assistant, those who are working every day in the rural level. And the communication has improved. Pregnant women are more coming to the hospital than home deliveries. So maternal mortality is going down. The main problem with the maternal mortality is the hemorrhage and eclampsia. These two issues really related. For eclampsias and hemorrhage, we have taken highest care, and every pregnant women are given incentives like few hundred taka per month to give them some sort of comfort. So all these are doing in this government. I'm hoping that we will achieve SDG by 2030. If not, but we'll be very close to that. It's very difficult when the population is very high and the health system is not up to the standard yet, and universal health coverage is not implemented yet properly. So still that we are doing better, especially community clinic. For 6,000 people, there is one community clinic. People are getting 30 types of free of medication, and they're getting primary health care there. And also the women MPs and women other representatives are 22% in our country. Is a very good number, and they're very vocal with and they're empowered with the Prime Minister. So whatever they're doing, they're involving more and more in the social issues, child marriage, drug addictions, many other social issues like violence against women. It has come down. Of course, during Corona time, it has gone up. It's coming down again. So overall, we are doing okay at the moment in the women front. And this government is very, very women friendly. So that is helping us well, because we need the political commitment, and we have the highest commitment in our country at the moment. Thank you.
Thank you so much, Honorable Millat. Thank you for telling us about these really interesting statistics and for also pointing out about the political will of the country. Thank you so much. The next speaker is Honorable Sophia Moermond. Honorable Moermond, based on your experience and expertise, what do you believe are the key priorities and the areas of focus that need to be addressed to effectively promote gender equality in health in Australia? And furthermore, how do you envision collaborating with stakeholders, including healthcare professionals, policymakers, and community organizations to drive meaningful change and improve the health outcomes for all genders in the country?
Excellent. Thank you for having me on this panel. There's an amazing amount of expertise here, which is wonderful to see. I feel that some of the big factors that we are dealing with is that we have a male-centric medical system here in Australia, and probably in other countries as well. What that means is that there is very little understanding of how women are affected by drugs, as the Honourable Fiona Patten mentioned earlier. And there's also more research dollars that are put into male diseases, male problems, male medications. So one statistic I came across was that the same amount of research dollars are going into fixing erectile dysfunction in men as to all gynecological problems in women. And that aids from pain to infertility, dysmenorrhea, polycystic ovarian syndrome, all of those things. So we need to make sure that those research dollars are going to be more equally divided between the sexes. And I agree entirely with the Honourable Katak there, and I hope I said that correctly, that we need very strong, quantifiable regulations around there. Just putting guidelines in place saying we need to put more money into things is not going to happen. It needs to be transparent from medical research companies, from universities, so that we can see the amount of money going towards male illnesses and female illnesses. The other thing that we deal with in Australia is that we have very much a multicultural society. We're also a really big country. With having this multicultural society, which is great, but there needs to be a clear understanding of intersectional feminism to understand the different challenges that different populations have. So when we are looking at white men in this country, they're pretty privileged here. They don't have to deal with sexism or racism, as a white woman, I too am very privileged here. I don't have to deal with racism. But then when you look at our Indigenous population and Indigenous female population, they have to deal with systemic and institutional barriers relating to both sexism and racism. So we are finding that in regional areas specifically, that women need to travel very far for proper reproductive care that relates to giving birth. In particular, they can't give birth in their hometown because there's simply not the infrastructure there to do so. This is very unfair, I feel. A mum should be able to give birth in her town with her family there, and she might have other children too that need to be cared for. So that inequality very much needs to be addressed. The other aspect of this, that in empowering women and girls in relation to their health, we need to make sure that they have a good understanding of their own physiology. We need to have education around that, and I think it would be useful for that education to be sex segregated to some degree, because there's still a lot of stigma and shame around female reproductive function. And when you're looking at girls who are getting their periods at 8, 9 years of age now, that is very uncomfortable. They're getting teased because of that by boys, which makes it even more difficult for them to deal with. One thing that we are helping girls with at the moment is that we are having more support for period products, where schools are now giving out free period products for girls. So at least the imbalance in period poverty is being addressed in Australia. But basically, understanding racism, sexism, and dividing the money equally are two of the main things that need to be focused on. How do I deal with that? I speak to people, I talk to healthcare practitioners, I write letters, and I put in submissions to various committees to make sure that they are looking at problems relating to health from an intersectional feminist perspective.
Thank you so much, Honorable. I think thank you for pointing out about shame, stigma, and education, and finally pointing out about intersectionality in gender. So thank you so much. Next, we have Honorable Anjana Bishankhe. Honorable Anjana Bishankhe, I wasn't able to introduce her before because she joined a little later. Honorable Anjana, are you here?
Yes, I am here.
Okay,
Yes,
perfect.
I am here.
Perfect. I'll just
Yeah.
introduce Honorable
Little bit
Bishankhe.
problem.
Yes,
Yeah.
Honorable Bishankhe is a Nepalese politician and serving as the member of House of Representatives elected from Kathmandu 10, province Bagmati. Honorable Bishankhe, we have a question for you in the context of Nepal. Poverty is known to have significant implications for both gender equality and health outcomes. In the context of Nepal, how do you perceive the intersections of gender, health, and poverty? What specific policies or initiatives have been proposed in Nepal to address these interconnections and ensure that gender-responsive approaches are taken to tackle health disparities among different socioeconomic groups, particularly women? The floor is all yours, Anjana.
Thank you. Thank you so much. I'm starting. In the context of Nepal, the intersections of gender, health, and poverty are interact and deeply intertwined. Women in Nepal experience significant health disparities influenced by various factors, including their socioeconomic status. Unfortunately, poverty compels the challenging women face in the issue of healthcare. Nepal has proactively taken significant step of establish can you hear me?
Yes.
Yes, Honorable,
Yeah,
we can hear you.
Yeah.
Okay.
Supportive policy environment for the gender equality and equity in the health. Normally, Nepal's new constitution, especially Article 38, enhance the women's right. Nepal has introduced the essential legislative measure such as enduring the Self-Motherhood and Reproductive Health Right Act in 2018 and the corresponding regulation in 2020. This act emphasizes the government's commitment of safeguarding women's health and reproductive right. The Safe Motherhood and Reproductive Health Program in highly prioritized program in Nepal's public health initiatives. Nepal's formal health system are blasted by the approximately 52,000 dedicated female community health volunteer FCHVs who works voluntarily nationwide, remote area and the urban. Their invaluable effort has gone global appropriation for reducing child and maternal mortality rate. The FCHV program has not only made significant contribution to improving people's health, but he has also played a crucial role in empowering women to participate in political position, including elected people's representatives in same case. Furthermore, the country is committed to promoting gender equality in health decision-making process initiatives to increase women's representation in parliament, health committee, and policy-making bodies seek to foster gender responsive policies that effectively address health disparities. The second question.
Honorable, we can take the second question a little later. We have some more speakers. We can take that later.
Thank you. Thank you so much.
Thank you so much. That was amazing. And thank you for such brilliant points. We'll move on to our next speaker. The next speaker is Ravindra Garimella. Like Ravindra, sir, you have had experience in the Lok Sabha which is the lower house of the parliament in India, for over 30 years. So as a former joint secretary in the Lok Sabha, you have witnessed the evolution of the Indian parliament in terms of gender representation. While there have been notable successes, such as the increase in the number of women parliamentarians, there have also been persistent challenges. Could you shed some light on the progress which has been made in enhancing gender representation in the Indian Parliament over the years? But additionally, what we'd like to know more is that considering both the successes and failures, what further measures or initiatives do you believe can be implemented to promote greater gender equality and inclusivity in the parliamentary representation, particularly in the context of addressing gender and health issues effectively? The floor is all yours.
Thank you very much, Paramita. And it is amazing to be amidst the distinguished panel of speakers on a very topical issue. Addressing the gender sensitivity issues with a focus on health and empowerment of women in the legislative bodies are intrinsically linked. As a joint secretary legislation in Lok Sabha, the lower house of Parliament of India, I have observed over the years the strides which have taken to enhance the representation of the women in the parliament. I'm audible, I guess. Yeah, women in parliament, but also along with, we had challenges which demanded and needed an action. So particularly, we have seen the rise in the increase of number of women parliamentarians from 14th Lok Sabha onwards. From 14th Lok Sabha, the members were 45 out of 545 members, which was 8.4%. In 15th Lok Sabha, it has increased to 52. In 16th Lok Sabha, it had increased to 69, and there has been a commendable, notable increase in the current Lok Sabha, which is 17th Lok Sabha, which is 78. So recording a increase of 14.4%. While this is a notable increase, but I would hasten to add that there is a long way to go. But the positive aspect is there has been a consistent increase. And coming to the upper house, the Rajya Sabha, where the women representation was abysmal in 50s, it is now 32. It is also increased. The political parties are nominating, they are more and more women parliamentarians. Alongside with this, there has been there has been endeavor through the constitutional 73rd and 74th amendment, they had which has facilitated the local body governance at the urban level and at the panchayati raj institutions. There has been a reservation for women, so that had played a crucial role in enhancing the voice of the women at the grassroots level, are also addressing the health, the gender sensitive concerns as well as the health concerns. And then we had another significant development, that we had the first women speaker, Srimati Meera Kumar, in 15th Lok Sabha. She also took a personal interest in that, followed by Srimati Sumitra Mahajan in 16th Lok Sabha, which held a national conference of women legislators. They had come from grassroots. They were in Central Hall. They were given a platform to address various issues. And this was followed by a two-day conference in Thiruvananthapuram on gender sensitive issues in 2022. We have towards the initiatives for gender participation, a lot of initiatives are needed and some initiatives have been taken. Like we have a standing committee of empowerment of women, which is actually specifically looking the gender sensitive issue with the health specific concerns like maternity and child mortality, and improving the level of the and decreasing the girl child mortality, and increasing the child enhancing the role and improvement and the progression of the girl child. And then we have a department of women and child development. And then of course we have lot of challenges, but then as some of which honorable member Srimati Fauzia Khan had already mentioned about ASHA and Anganwadi workers, the endeavors are on, as because without taking much of the time, I find being at the table of the house, I find more and women parliamentarians raising the gender sensitive issue with the specifics on health. And finally, the challenge is to get a women reservation bill in Parliament and Rajya Sabha, which has been passed in Rajya Sabha but is pending in Lok Sabha. And thank you for this opportunity, because I appreciate the time constraints. Thank you very much.
Thank you so much, Ravindra. I think because you have had so much experience, you were the best to talk about this evolution of the Indian Parliament. And yes, thank you so much for pointing out that how I have also recently read how the issues on health and gender have taken so much prominence in the Indian Parliament. Thank you so much. Honorables, we have done one round of questions. Now we have some time left, so maybe we can take 2 or 3 more questions if you honorables allow. So may I?
Yes, please.
Okay, perfect. Thank you so much. I love the enthusiasm here. So maybe Honorable Lamb, we can take a question from you. That is that okay, Honorable Lamb?
Yes,
Yes.
please.
So you have been the Dean of the Faculty of Social Sciences at the University of Macau, and you are currently heading the Center of Communication. So I think effective communication, it plays a vital role in achieving global health equality and addressing gender and health issues. As a parliamentarian, you have a platform to advocate for health policies and initiatives. In your experience, how do you believe that communication can be better utilized by parliamentarians to raise awareness about global health disparities and gender-related health issues? The floor is all yours.
Okay, thank you very much, Paramita, for your question. I think, thank you for this question. I think I studied communication, and of course, I believe in communication as well. And so I did not have a lot of experience as a parliament when my term was short at that time. But I think that before I was elected, and also during the time when I was the legislator, I always kind of engaged the community to kind of promote their own concerns. So more or less like I think all of us doing, we speak for themselves, and then we speak their heart, and so, and we also try to communicate their concern, you know, from the concern from one community or one group of people to the other group. And so I think speaking for people's heart, okay, and so that would be one major element that we should kind of include in our promotional strategy. I believe that's one thing. But at the same time, because I was kind of the very minority in the parliament, and so kind of a neutral moderate, and so if I need to let other people agree with my proposal, I need to actively engage with other parties as well. So I think that another kind of strategy is that I try to bring the mutual benefit you know, to other people as well. And so, for example, if we I still remember the time when we advocate for the anti-domestic violence law. I was not elected at that time, but when we kind of proposed that, and we heard a lot of there were a lot of arguments. Actually, we have a big debate in the society because there were quite a number of male legislators. They didn't like the idea of criminalize gender-based violence, and then they believed that was wrong. And so, because we still in Macau, even that, okay, we look kind of modern, you have a lot of luxury casino, but I think in a lot of people's mind, we still have the patriarchal value. So at certain point, people believe that it is not a big deal to, you know, hit their wife or abuse their wife with a kid, which was not very fortunate. So you need to kind of really communicate. You cannot just okay, we can shame on some people's idea, right? But at the same time, very soon I find that was not very useful. But we may need to tell people that actually criminalize gender-based violence would be a way to really promote the idea that this is something wrong. And so our point was not to put every man in jail. It was not the point. But then if we have this kind of measurement, so we just use this threat of going to the jail as a very strong message. And so that was also another way that we tried to tell people. So we would tell, once we send a strong enough signal, it would be much easier for us to make the whole society to understand this is an important issue. So I think this is something I can kind of sum up in a way that we try to emphasize the mutual benefit. If we kind of pass the law, we agree with the same idea. So I think that would be another communication strategy I try to practice over the years. I hope that would be, yeah, kind of.
Yes, thank you, Honorable Lamb. I just comment by saying
Got it,
that
yeah.
keeping community at the center of communication strategy is the best way forward. So thank you so much for pointing that out. Honorable Fauzia Khan, if I may take another question for you, are you there?
Yeah, I'm there.
Okay, Honorable.
Please go on.
So
Yeah.
let's talk about women in leadership positions in health. So women make up 70% of the health workforce globally and represent about 90% of frontline health workers, but hold just a quarter of the leadership positions. So how can we work towards rectifying the gender imbalance in leadership positions within the health sector to ensure greater representation and opportunities for women, leveraging their valuable expertise and contributions?
Well, when you talk about women in leadership positions, I think it's all over the world and in every sector, the story is the same, that although women have the capability, although women have the workforce in that sector, and yet they are deprived of leadership positions. So the same applies to the health sector as well. So that is why this gender imbalance has to be rectified. And if it has to be rectified, it is just not a matter of social justice. It is also a strategic imperative. We need to do it. We were just talking about women in parliament, and Mr. Ravindra also spoke about the reservation that we have given women in the local self-government in India. So here we have 50% women working in the local self-government, but at the same time, enough women, we cannot be happy with the position that we are at today, 14%, and that's even not even close to the global average. Some countries have brought in this quota system, and with this quota system, some countries have given women positions up to 60%, 65%, Rwanda, other Latin American countries and all. So I think we need to do something really big, something, a jolt. It just cannot come at a slow pace. So whether it's the health sector, whether it's any sector, quotas, I think, are the answer to give it a 3-time more impetus. And this we have to do in the health sector as well, because as somebody, one of the participants was just saying, that everywhere in the merit lists, you see women are ahead. So if women are ahead, why are they not in leadership roles? And unless they are in leadership roles, how can we change the situation really? So we need to work on it. We need to have a more inclusive, responsive healthcare system as well, where we need to address structural barriers. We need to invest more in leadership development. We need to foster a culture of inclusivity. We need to implement a gender responsive recruitment policy, new, better policies, practices, and we need to advocate for policy changes. All of us have to fight for it, struggle for it. We need to engage men as allies. As they are not our enemies, they are not our opponents, they are our allies, and we need to work with the men as allies. So I think the kind of insecurity, if it does exist in the men's world, we need to eradicate that, saying that, no, we are not here to threaten your position. We are here to work alongside so that we have a better society. And that is why we need to have gender representation in leadership roles, even in the health sector, and so that we can contribute effectively as leaders in the healthcare system as well. But I feel this has to be looked at in a very, very wholesome way. And all women, sometimes, it is the woman who's the greatest enemy to a woman. And that is why women should take this up very strongly, come forward, and let's change the world together. Thank you.
Thank you so much, Honorable. There was a lot of positivity, and thank you for pointing also out the structural barriers. We'll take the last question for today because I don't want to hold the honorables for too long, as I don't want this session to end, but we'll have more such episodes. I think the last question, Honorable Patten, if you may take that. Okay. So in light of the persisting global gender health inequality, what policy interventions or measures do you believe are the most effective in addressing the root causes and promoting equitable access to healthcare for women and girls worldwide? Honorable Patten, you're on mute. So
thank you. And I think everyone here today has articulated some of those solutions. And I think Dr. Khan just then was so powerful in this is about equity and equality. And when we can reach equality in our respective countries and gender equality in our respective countries, the rest, equitable access to healthcare, will follow. But for me, one of the main policies, and I've heard this repeated by the honourable members, is education. As long as we are teaching our women and girls and giving them the same opportunities worldwide, that will also increase our access to healthcare. Now, whether that's sex education or whether that's just the right to an education. I think the role of religion has something to play. And we know even in a secular country like Australia, a lot of our healthcare is run by religious organizations, and that impacts the way that women can access reproductive healthcare, for example. And I think certainly in other countries, you would find the same. So I think we need to consider the roles of religion, but really the roles of education. And fundamentally, if we have gender equity in our society, then our healthcare will follow. Yes, we need quotas. Yes, we're seeing quotas on health boards now in Australia to ensure that the leadership in our health areas is balanced. But even with those quotas, there's still much more to do and it goes back to gender equality as a whole, whether that's equal pay, equal access to education, equal access to childcare, so men can play that role as well in the looking after their families. But it's those fundamental areas that will lead us to gender equity in healthcare.
Thank you so much, Honorable Patten. And I'll just wrap up the session today by saying that gender equality and women empowerment are absolutely essential and imperative for better overall health outcomes for all. So I just wanted to say thank you to everyone who was part today. I had so much to learn, and we really hope that we can continue these conversations in the future. I will keep you updated with more of the Let's Talk Health series and also the Unite events. Thank you so much, Honorables. I will be in touch with you.
Thank you.
Thank you, everyone.
Thank you so
Lovely to
much.
meet you all.
Thank you.
Bye-bye.
Have a
Bye.
great day. Thank you.